Hold. Go for it, Shona. 7 o'clock.
Okay. So what I'm presenting today was a baby born at 32 weeks gestation. Our protocol for cranial ultrasounds is less than 32 weeks, so this baby didn't fit the criteria for the regular 137 and day 28 protocol. He was born by spontaneous preterm vaginal delivery. He weighed 1.98 kilograms, and he actually was scanned because he had a temperature instability overnight where he was pyrexial for quite a bit of the night. So the first one, this is the frontal lobe. You can see the orbital.
Yep, perfect.
And the interhemispheric fissure, it looks quite enlarged. It's kind of off to the right, and you can see the large dilated ventricles, which you usually wouldn't see on this frontal lobe scan. So this is bleeds that you can see here, around this bit. You can still see the interhemispheric fissure, the dilated lateral ventricles with the bilateral bleeds. The corpus callosum, which I think is here.
Yep.
Yeah. And the Sylvian fissures at the side.
Perfect.
I'm not sure what this is. Is this the...
Yeah, they're the temporal horns. They're dilated. So basically, when the ventricles communicate, these are the lateral ventricles, but the ventricle basically is a little C-shaped like this. So what you're seeing is a cut through it. And really, when you see that cut, you see the lateral ventricles, which have got a clot in them. But then you also see the temporal horn, which is quite dilated. So it's a brilliant image. It's absolutely brilliant. We'll talk about it, but it's absolutely brilliant. Carry on. Yep. Not very brilliant for the baby. Sorry. Yeah.
So again, the interhemisphere, the corpus callosum, and the septum pellucidum. Also, this is the bleed that looks like it's kind of resolved kind of blood here.
Yep. How old is the baby, Shona?
Sorry, he's day 14 when he got this scan done.
And that was the first scan?
Yeah, that was the first scan, and it was only done because of his pyrexia overnight.
Sure.
So he was treated for query sepsis and had a lumbar puncture done as well. So I think this is
it's a perfect C3 view. Yep. Go for it. Yep.
Septum pellucidum here.
Yep.
And obviously the ventricles at the back here. And you can still see the Sylvian fissures here.
Yep, that is actually the third ventricle coming in.
Here.
Yeah. And the foramen of Monro is basically blocked. So with the lateral ventricles, large clot on the left side, and then the temporal horns are dilated. So, yep, it's a beautiful image again. My only comment, I suppose we'll come back to critiques at the end. Carry on, please.
Okay, so this is the C4 one, where you can see the bilateral dilated ventricles, and is that the choroid plexus?
Yep. Just over here, laterally. Yep.
Okay. Okay, and this is a C5 one, which...
Yep.
Again, you can see the interhemispheric fissure. And I'm not really sure about this bit here.
Yeah, basically trigone of the lateral ventricles, and you've got clot within the ventricle.
So is this
bilateral. Yeah, this is a clot, and this is choroid plexus. When you see kind of blood that's free in the ventricle, it's usually a clot because choroid plexus should have an attachment. This choroid plexus is very, very bulky. So from our perspective, I suspect there's an element of bleeding which has happened, which is reorganizing. But it's a beautiful image.
Okay.
It's brilliant. Yeah. Dilated posterior horns.
Yeah.
Yep.
Okay, next one.
Yep, go for it.
So this was just we were measuring to see how big the ventricles were here. So the one on the right, our right, is 1.8 centimeters, and other one's 1.46 centimeters.
Yep.
Okay. So this is the midline.
Yep.
Here is the corpus callosum
Brilliant.
up here.
Yep.
And I think you can see the fourth ventricle.
It's a little bit tricky. You can definitely see the corpus callosum, ventricle entering into the aqueduct, and then kind of the third ventricle becomes a little bit obscure, and it's difficult to see the fourth ventricle. You'd kind of guess that that is the cerebellum. That's probably the vermis, and the fourth ventricle would probably be around here.
Yeah.
Maybe you've got a little bit of blood, you've got loads of blood there, and obviously that's draining through. So the question from our perspective is whether blood's obstructing the ventricular system at this point, and hence we're not getting a very clear view of it. But yeah, nice midline view. Uh, I think it's tricky when you have intraventricular hemorrhage dilated ventricles sometimes to see the corpus callosum all the way to the anterior horn because you have significant dilatation of the lateral ventricles in your image, but very nice. Yeah.
I took another one of the
Oh,
midline.
beautiful, beautiful. Yeah, now you can see everything. Yeah.
Okay.
So, yeah,
And I'm a bit kind of stuck with this. I think is that the ventricle there.
it is the ventricle, and you're going out to the parietal cortex and the temporal lobe on the right side. And because you have ventricular dilatation, your kind of frontal horn of the ventricle is coming through at the moment. But yeah, that's good. Uh, Did you go a little bit further out?
Yeah, yeah.
Lovely. Brilliant.
So that's just the ventricle, isn't it? Yeah.
Yeah. Very nice
Is,
C. Very
is
nice
that
C. Yeah.
is that a bit of blood here?
Yes. That's
Yeah.
clot. Yeah.
Okay. And that's it further out.
Yeah.
Okay. And this is the left side, which I think that's quite
Yep.
a big bit of blood there.
Yep. And the
And
hemisphere is not involved. Very well done. Well done.
that's it. So this baby had bilateral dilated ventricles with evidence of resolving bleed in both ventricles.
That's brilliant. Just gonna let a few more people in. Yep, that's brilliant. Let's go back to your first image. So immediately, as soon as you see this image, a few things stand out in that this baby's 2 weeks old. You have pyrexia with intracranial kind of dilatation of the frontal horns. Now, just an awareness, the interhemispheric fissure here is quite uh, bridged. It's quite dilated. And that just always raises the possibility that you may have a subdural collection. You can never be sure, but a good thing to do in this view is to put Dopplers on and try and see if you can see any element of vascularity nearby. And the real challenge from our perspective is, I mean, we've had a case, I think 2 years back, who had completely normal brain but had significant intraventricular, sorry, interhemispheric fissure dilatation. And just when we did an MRI, we captured some subdural blood. So did this baby have any instrumentation? No instrumentation?
No, it was a normal preterm delivery.
And resuscitation at birth?
He didn't require any resuscitation and he only ever had CPAP.
Okay, very interesting. I mean, at 2 weeks, he's developed clot. So yeah, it's a little bit unfortunate. He's for a 32-week steroids. Mother had steroids.
Your mother had steroids.
So very unlucky, very unlucky. But frontal horns are dilated. Definitely, the interhemispheric fissure is wide. So again, just sometimes raises the possibility that might be a collection, may not be the case, but you should follow it up going back. So let's go to your next image. And clearly, very, very nice image. Again, you've got the whole of the brain. I would say the magnification and depth are really good, and that I can see all the anatomy. I've got the Sylvian fissures coming up as a Y, and I've got these dilated ventricles with clots on both sides, clot on the left being more than the right, and the left ventricle being more dilated than the right. Temporal horns. So just if you see these areas here, these are basically the temporal horns and the temporal lobes. Carry on. Yep, and now you've got basically the view in which you do your ventricular indices with the Y. So again, corpus callosum, you've rightly described them. And really what you'd have is a communication with the foramen of Monro entering into the region of the third ventricle. And that's kind of where you want to do your VIs, which you've demonstrated beautifully. Again, just the interhemispheric fissure here, just an increase in the axial space in between the two fissures. So the question again that I would raise is whether you've had a small collection of blood there, possibly. The other possibility, if you have infection in situations like this, is again considering the possibility of meningitis. So your lumbar puncture was normal, I gather.
Yes, it was normal.
Lovely. Brilliant. Brilliant image. No, nothing to critique. You've got the cerebellum starting to come into view at the back. It's really good. Yeah. Yep. Uh, Again, similar findings. What's this, Shona, at the back?
Where here?
Yep.
Um,
It's cisterna magna. So basically,
okay.
as the cerebellum comes into view, you have a small area that's echolucent, which we call the cisterna magna. Normal kind of width is about 10 millimeters, best measured in the sagittal views and in the cerebellar views. So, but beautiful image. I think your depth and your gain setting. I mean, is this the first scan you've done, or have you done other scans? Because it's a really nice image. It's beautiful. Carry on. Yep.
Can't hear you. Look.
Sorry. Have we lost Shona for the time being?
I couldn't hear you there.
Can you hear me now?
I can hear you now.
Yeah, lovely. Carry on. Lovely. Yeah. Brilliant. Nothing to critique in this image. You have a little bit of dropout on the left side. Uh, it, it's probably because you're moving back and it's just keeping your probe in the center as much as you possibly can. That's my only comment. Otherwise, this is a nice image. Carry on. And then your occipital horns are dilated at the back. Brilliant. So let's go to your midline image because that's a beautiful image. Yeah, the one can. So it's a nice image. You can see the corpus callosum. You can trace it all to the anterior commissure. And really, what you've got is a dilated third ventricle over here, which indicates that the clot in this midline is basically obstructing the aqueduct. And this third ventricle being dilated kind of means that you might not have CSF coming through. So you don't see the fourth ventricle very, very well. This is kind of where you'd see it. This is the cerebellum. I suspect this is probably where the vermis is. This is where you'd see the fourth ventricle. It's quite hypodense as opposed to being dark. So again, whether there's an element of blood that's there that's hypodense in this particular situation, because it's probably been there for a while, not very echogenic. The question is whether you've got obstruction at the level of the third ventricle uh, and below, which basically lowest level of the third ventricle means the third ventricle is dilated. It's the back pressure that's causing your ventricles to dilate. So it's a very nice image. Nothing to critique for this at all. Yep. If you could go a little bit out, further out, just the best thing to do is try and see if you can lose that ventricle as much as possible, just to make sure that you've got the outermost part of the parenchyma and there's no bleed. I mean, pretty much there's no bleed on your coronal views. So that's the only thing I'd say.
Okay.
Yeah, and this is a brilliant image. Nothing to say. You're perfect. See, you've got clot there on the right. Yep. And just we had a question from Gopati on the left side in the ventricle. Is it a cyst with organized hematoma with thick wall? So what it is it's a clot which is basically reorganizing. To start off with, the bleed would have been echogenic and bright when the blood was fresh. But as it clots, we know that changes take place, iron is released, we tend to have hemosiderin, and all of those things means that really the ability of sound waves to penetrate in, because there's no change in the echogenicity as sound waves move through this, means it gives you a slightly hypoechoic kind of a view. Gradually, what you might find is this blood will get absorbed, and you might find that you're just left with a cyst later on, maybe as the ventricles become less dilated, or it might resolve completely, or you might find that the clot persists for a very long period of time, weeks, and you can continue scanning until this becomes either arrested hydrocephalus or improves. But yep, that's the kind of uh, spiel on it, Gopati. That if that hope that answers your question. Carry on, Shona. Brilliant. You just need to move back a little bit because you're losing the frontal area. So again, you're getting the back really nicely, but you're just losing a little bit of your kind of frontal horn.
Yeah.
So it's just
Oh,
moving your probe. Just uh, forwards a little bit. You're probably further back, and hence why you're losing. But otherwise, these are really nice images.
thank you.
I would save them to your logbook because I can sign off virtually everything based on that image.
Okay, thanks. I've put it on already on my
Lovely.
Dropbox.
Any other scan to share?
Um,
Only if you have one, Pript.
I've actually got another couple.
Okay, are they ready to go?
Yeah.
Let's have a look at one more because we only have two people presenting today. It's you and Alberto. So
Sorry, I've lost the Zoom now.
no problems. While you're bringing it up, maybe I can get Alberto to share. Alberto, are you ready to share?
Yes, I'm ready. Just a second.
Go for it.
Um, Sorry,
No,
just
take your time.
entering.
Take your time.
It's the first time I share.
Yep, no problems.
I'm not sure if I'm doing it right. Share.
Brilliant.
Yes, this,
Yep,
yes. Okay.
brilliant. So you just have to go to full screen.
I
Yep,
changed the monitor. This one.
perfect. Yeah, perfect.
Okay. Good morning, good afternoon, and good evening to everyone. In Portugal, it's London time. I'm bringing a simple case. I'm a beginner with cranial ultrasound. Not so interesting like Dr. Shona's case, but better for the child. We have a 30 years old mother with a pregnancy without problems. And at 33 weeks and 4 days, she has a premature rupture of membranes. And the obstetrician started antibiotics and dexamethasone. She only has time for 2 doses of dexamethasone, and the delivery was vaginal with 2.3 kilograms and Budapest 999. No need of ventilatory support, and because of prematurity, we transport the child in an incubator, breathing normally without supplement oxygen to the NICU. The blood venous gases, nothing special, analysis okay. We started caffeine, fluids, and antibiotics because of the prematurity. The blood culture had no growth of bacteria, and the CRP were negative, so we stopped antibiotics at 48 hours. On day one, our radiologist made cranial ultrasound and saw a small cyst of 2 millimeters on right. And on day 5, I made this echography because the first was very soon.
Brilliant.
On C1, first, the image is not like I would like, more centered. Sorry, I'm looking for a marker. Yes, I would like the interhemispheric fissure here, but it's here. We have the frontal lobes with the blush, normal blush, the orbits, and we have some dropout here. The fontanelle was small, and the baby has lots of hair.
Yep, for a 33-weeker, that's a brilliant image, Alberto. Trust me, I wouldn't be able to get better. That's perfect. The dropout is expected. You're going to have a small fontanelle in a 33-weeker. But I mean, just look at your gain settings. They're brilliant. You have the frontal orbits bone bright. You have the orbits which are visible, interhemispheric fissure. It's a brilliant image. I have no critique. Please carry on.
Thank you. Then C2, we see the corpus callosum. I first learned with your colleague with the hyperechogenicity. It was the first time I understood what was the corpus callosum. And here we have the cavum septum pellucidum, and here some lateral ventricle. Yes,
Yep,
the orbits,
perfect.
so it's still.
Yep.
Then C3, I see the third ventricle, the thalami on each side.
Yep.
Cavum, interhemispheric fissure, cerebellum, here, I think.
Yep. Just starting to come into view. Yep. Beautiful. Perfect. Yep.
Now on C4, I think that is the trident. Is that we saw
Yep.
you
Yep.
call the trident? Yes. And the dancing lady.
Yep.
The dress looks well for me. I don't
Yeah, it
see
looks
spots.
brilliant. Yeah, no spots, just for everybody. The dancing lady is also, so just why we call it the dancing lady, so that people understand that's the dress, the head, the arms. So brilliant.
I think this area is the area of the hippocampus.
Yep.
Okay. The thalamus.
Yep. Perfect.
I see a bit of choric plexus, lateral ventricle,
Yep.
and cavum of septum pellucidum here.
Yep. I agree.
Okay, thank you. Now C5, I see where we are on trigone. I see the choric plexus here, lateral ventricle, interhemispheric fissure. I see a bit hyperechogenic here, but I think it's a blush because I don't see in other views, and when adjusting, it disappears, and I think it's normal.
Perfect.
On C6, we see the occipital lobes and the blush of the occipital lobes,
Yep.
and interhemispheric fissure, Sylvian fissure here. I think that's it. Sulci, gyri here.
Yep. The images are absolutely fine. Wow. I mean, the midline images, uh, uh, this is absolutely fine. The gain settings, you've got such good differentiation. really nice.
Thank you. I have a bit of dropout here. And
I wouldn't be surprised with a baby with a small fontanelle moving back. I can see you're in the midline. You've got really good coverage over here. So I suspect the fontanelles are just narrowing as you move backwards. So again, it's really challenging, but this is good enough. This is perfect. I would have no complaints.
Thank you. Now, sagittal view.
So
So midline, sagittal view,
I,
S3.
I just need to interrupt you there,
Sorry.
Alberto. Yeah. No. Go back to this image, the one that you were just
Okay.
showing us. So for those of you who want to see a textbook midline image, I would say that this is the textbook midline image. It is beautiful. You've got the corpus callosum, genu body, the posterior end beautifully visible. You've got
Okay.
the aqueduct, the ventricular system, and the cerebellum with the fourth ventricle in the vermis. It's absolutely brilliant.
Thank
Can
you.
you kindly annotate,
So,
please?
Go for it, Alberto. You can tell everybody.
okay, fourth ventricle, vermis. I think here is the pons, corpus callosum, cavum septum pellucidum, thalamus, I think.
Yep.
And I don't know what this is.
It's a small prepontine cyst. So
Okay.
the area of this is basically the pons that you can see over here.
Yes.
And this is
Yeah.
probably a
Yeah.
remnant. It's usually over here, but sometimes you see small remnants above and below. So it's basically a
Okay.
small prepontine cyst. Nothing that I would be concerned about.
Thank you. Here we see the cingulate.
Yep,
Here.
the gyrus.
Okay. Then S2, parasagittal right. So the thalamus, the caudate, lateral ventricles with choroid plexus, caudothalamic groove.
Remember, for every
Cerebellum.
yep. So just remember, everybody, this was a slit-like ventricle. So you've been able to demonstrate the chorothalamic notch in the choroid plexus. My only comment on that right side is uh, you've annotated very nicely. There's a small cyst within the choroid. Yep,
Yes. Yeah.
brilliant. And
Yes.
I suspect you can see it on the coronal view as well.
I'm not sure. I'm not sure, but I'm a beginner.
Yeah. So if we just go further back,
Maybe, I don't know, here.
no, further back. No, you're right. I can't see it on the coronal view. My apologies. Carry on. Yep.
You're welcome. I'm a beginner. I could have missed.
No, not at
Okay,
all.
so a small test here. I saw in few images. And then lateral parasagittal right, I think you give a different name, tangential parasagittal, I think, right?
Yep.
Here we are at the level of the insula with Sylvian Fisher here, I think. Parietal
Brilliant.
lobe, temporal lobe, I
Correct.
think. Yes?
Yep.
Thank you. I'm going to the left again. So on the left side, I'm on S4, parasagittal left. I see this here,
Yep.
thalamus, caudate, corpus callosum, okay, cerebellum. And I tried to see the size. It's a small cyst in the choroid plexus of 2 millimeters here.
Correct.
And I think I have some artifacts. This image is not very good. And this,
Uh,
but I don't confirm in other views, but I think the only one is this one here.
I agree. I think you just have basically an overlap between the midline and your kind of left side, and it's because your ventricle is slit shaped. It's
Okay.
so it's going to be very tricky to kind of demonstrate the ventricle because it's so small, but you've captured it very nicely. Yep.
Okay. Thank you.
So you've kind of got two choroid plexus cysts.
Yes, one
Yep.
on each side.
Yep.
Side. And now lateral parasagittal left, the insula again, and the Sylvian Fisher, and lots of sulci and gyri. So, and the parietal and temporal lobe, I
Yep.
think.
Yep.
And I tried to see the resistant index. Not to, I wanted to catch the resistance at the level of the genu, but I wasn't able to do that. So I tried below, and I have a normal resistant index.
Actually, you're absolutely right, Alberto. Below is easier because your angle of inclination is easier. So sometimes we don't take the ACA Dopplers, we go below that. And I will talk about the different vessels which are tributaries. And it is just as accurate because your ACA might be difficult to find, especially if you've got very small ventricles. So this is perfect. This is
Okay.
perfect. Yeah. Angle of inclination is also perfect. Well done. I mean, it's a beautiful image. I think both the scans so far have been absolutely amazing. Very little for me to do and say.
And now I tried Master You, very difficult. I was giving up, but my colleague put some air aside, and I had these views. Mastered view, I think is the fourth ventricle,
Yep.
the cerebellum.
Yep.
Uh, I don't see any problem, but I'm a
No.
beginner. I think the cisterna magna is here, but I have dropout.
Yep.
So, and this image I think is a bit better.
Yep.
For ventricle, I think here is the pons.
Yep.
Okay. And here I don't know the name. My colleague in Portuguese taught me about something of onions, like the
Uh,
layers of onions,
yeah.
I
It's
don't know the English word.
basically it's called a ciliated appearance of the cerebellum.
Okay.
And
Okay.
the reason for that is it's got a large number of convolutions and it's very bright. It's highly vascular as well. So it's just a reflection of a very well-developed, mature cerebellum at this particular stage. It's not smooth. Vermis in the fourth ventricle is definitely nicely visible. And I mean, considering this is a 33-weeker, you said?
33 weeks when I on day 4, 34 weeks and 1 day.
Sure. So it wouldn't have been easy. You would have had a very small mastoid window. So these are very good images. I mean, with the eye of faith, I can easily do the cerebellar measurements, have a rough kind of an overview. So well done.
Okay.
Well
Okay,
done.
thank you. And now my doubts.
Yeah,
And
go
not
for it.
only mine, my colleagues
Sure.
also have doubt.
Sure.
I think you do a lots of echographies with simple cysts, and we don't know when to stop. So when a simple cyst 2 or 3 millimeters, I think we don't have any problem with that.
No, no.
But when we have a multiple cyst, it's different.
So
And we don't, sorry,
yeah,
say.
I'll talk about that today. In that, really, what I'd say is that if you have a simple choroid plexus cyst, then really, from our perspective, this is a kind of a 33-week scan. Uh, if this was a term baby with a simple choroid plexus cyst, I'd stop there. If there were no other concerning features, the baby's not dysmorphic and there's nothing genetic that would worry me, then at that particular point, I would pretty much stop over there. But for a 33-weeker who incidentally has these findings, I think probably one more scan at term at about, I'd say, preferably, if you get to 37, 38 weeks, because a lot of these babies will go home earlier. I'd probably wait till that gestation to do it. I mean, if bad luck says the baby's there at 40 weeks, then really, from my perspective, I'd try and kind of do a scan at term, 37 to 40 weeks, repeat and stop. But if the baby is going to go home before that, then I'd do a scan at discharge. And a simple isolated choroid plexus cyst would not mean anything. Uh, it's size-wise, it's basically reflex most people think is abnormal areas of CSF production that kind of get walled off, or small intrachoroidal bleeds that might have happened in utero that basically become cystic. They're innocent and they usually, from our perspective, resolve completely. So I would tell the mother that we've seen them, but actually, as you've written, I would completely reassure that it's a finding that can be seen even in normal babies and that it doesn't really mean anything. It's nothing that we would worry about.
Okay.
But
Thank you.
there are other kinds of cysts. There are conatal cysts. There are subependymal hemorrhage with cysts, and then there's PVL. And we'll talk about them today when I do the presentation. Yeah,
Okay. Thank you.
my pleasure. So we have time for one more. Patricia, do you have a scan you could share?
Yes, I do. It was a very rushed scan,
No
unfortunately.
problems. Absolutely fine.
Not sure how to share this screen.
You can share and it will take off Alberto's screen automatically.
Okay, I'm trying to, I have a problem here. I'm trying to
No.
solve it.
So once you start sharing, Patricia, it will automatically
Yeah.
take off Alberto's screen.
I stopped. Okay.
Yeah.
So
Sorry.
I can see it on my screen, but I don't know that you can see it.
Have you shared?
Yes.
No, we can't. Not at the moment.
What am I doing wrong?
So stop share.
Okay.
And close your PowerPoint. And then just reopen your PowerPoint once again.
Yeah, I've got nowhere where it says to share.
It's a small green button at the bottom with an arrow at the top.
I'm sorry, I can't find it.
No problems. Don't worry. Okay. What we can do is, are you adding them to your Dropbox?
I've got problems with that. I don't know how to.
Okay, no
I
problems.
will find out, Alec. Don't worry.
No problems at all. What I'll do is I'll send you a step-by-step tomorrow morning just to make it easier, and I'll reshare the link with you. So for those of you who are using Dropbox, the easiest way to do that is to open the link on your computer, which will automatically open your folder. And that folder will basically have a copy of your logbook with the ACCS form, which is what I fill in after you guys finish. That basically, from our perspective, is your personal space. And if you open that folder on your computer and you have a PowerPoint on your desktop, all you have to do is drag that file and just put it into that file. And then it gets stored. And I can basically embed it in your Dropbox. So what I am going to do today is I'm going to talk to you a little bit about IVH. And from my perspective, what is really important is the other entity, which basically we call uh, periventricular leukomalacia. It's quite an interesting talk because really we talk a little bit about the pathophysiology. We look at the images, the epidemiology, but we also talk very, very briefly about prognosis of the different kinds of scans as we go along. In that, I think it's quite a crucial area. So is my screen visible to everybody?
Yes.
Okay. And I'm now full screen, audible and visible?
Yes.
Lovely. So I'm going to talk to you a little bit about IVH first. And really, I think what is important is that we define IVH in a certain way, but the pathophysiology for IVH, especially for grade 4s, and for how you develop post-hemorrhagic ventricular dilatation can vary. But really, periventricular intraventricular hemorrhage is a disease that primarily affects the germinal matrix in preterm babies. And we know that as you become more mature, especially after 32 weeks, the germinal matrix tends to basically become more mature and that it has much better basement membrane with coverage of pericytes and a much higher kind of connective tissue layer, which means its vulnerability to changes in blood pressure uh, make it less vulnerable to bleeding. But under I would say really 32 weeks of gestation, you tend to have immaturity, which increases directly proportional to gestational age. And I mean, in a 22, 23 weeker, you have virtually no parasites to support that particular area. So any fluctuations in blood pressure, hypocarbia causing ischemia, and then suddenly reperfusion, all of these things can really cause those areas, that fragile germinal matrix, to kind of rupture. And when that happens, basically blood spreads. Now, where is the germinal matrix, first of all? So I'll show you in a later image. I talk a little bit about epidemiology first. My apologies. So what we know is that the incidence of IVH really varies, and you'll find that there are some units who have very low IVH incidence. Working in Southampton, our IVH incidence was less than 5%, and actually seeing grade 3 and grade 4 IVHs was uncommon. Really, I'd say that mainly babies who were transported or outborn, or who came to us and had quite difficult kind of clinical course, were the babies who were more vulnerable. But our own rates for babies who were delivered electively with good antenatal steroid cover in patients, it was uncommon for us to see IVH. But actually, if you look at studies, it varies between 3 and 50%. And if you look at the incidence of kind of grade 1 to 4, it gradually goes on improving. Now, the paper that basically talks about this is a paper that looks at a quality improvement project that was done by colleagues in Brazil. But the overall frequency of kind of grade 1 to 4 decreases from 17 to 3.8%. And this is kind of figures that come from an era of quality improvement where they've really worked really hard to reduce their rates of IVH. Now, in terms of when it occurs, well, that's interesting because epidemiology is changing, but really older studies showed that about 90% of intraventricular hemorrhage occurred by the third day of life, and about 50% of these occurred within 24 hours. And that's why I would say that really our three kind of days is quite crucial, in that for our extremely preterm babies under 26 weeks, you want to minimize interventions, you want to minimize any kind of, I would say, handling. You want to not do any kind of suction in these babies unnecessarily. You want to make sure they're not hypocarbic. You want to keep them normothermic throughout. And really, you want to manage their blood pressure to keep them normotensive based on your unit guidelines. Naturally, there's a permissive kind of an approach to that as well. But that being said, units who kind of practice these kind of approaches tend to have lower rates of IVH as compared to units which basically don't. And then the most important other aspect is obviously preventing preterm delivery alongside antenatal steroid cover. And antenatal steroids basically work by improving parasite coverage, by reducing the inflammatory response that you might see with an IVH, and have quite a significant effect. In fact, for those of you who might still think that we give steroids to make the lungs more mature, actually, in babies under 26 weeks of gestation, they don't have enough alveolar pneumocytes to be able to generate surfactant, even if you give them antenatal steroids. So the real reason that we give antenatal steroids under 26 weeks is basically through trial evidence, the benefits demonstrated are reducing the risk of intracranial hemorrhage. And that's quite important. So, for units who have high rates of antenatal steroid coverage, you'll find they have lower IVH rates. And this is a very nice study which basically looks at the global differences in incidence of intraventricular hemorrhage in extremely preterm babies. So kind of babies who are under 1,500 grams, under 28 weeks of gestation. And really what you'll see is that with increasing gestation, the IVH rates come down, but they're quite high. And this is a Romanian unit in 2014, where you'd find that about 30% of babies at 28 weeks were having IVH. And really for babies at 25 weeks, they didn't resuscitate babies below that. It was about 70%. So that's quite high. But clearly they've implemented a bundle of quality improvement. And in a similar number of babies over a period of 3 years, they've been able to bring these rates down quite significantly across all gestations, even though still you find that at 28 weeks, the rates, I would say, would probably at above 10% be quite high still. And some of this might be because this is a unit that basically takes in outborn babies who really, from our perspective, may not have steroid cover, where the mothers may have delivered in centers where they have needed transport. And all of these risk factors then can't really be worked with. So, there's a lot of push towards centralization these days. Similar comparative figures for places like the States and Hong Kong. I mean, you can see that really in the States at this particular point, they have the lowest rates of IVH for babies who are 23 weeks, which is about 30%. Uh, I know that some units in the state actually have incidences now, as we speak, of less than 10%. And really, our numbers in Southampton were very small. But when we looked at our 3-year averages, our rates used to be less than 5% for grade 3 and grade 4. Our overall rates were very similar in the range of about 10 to 12%. So again, we're a unit where inborn babies get very high steroid cover. There is a lot of active management in that 24 weekers will have cesareans where appropriate. And there's a lot of, I would say, an active approach that's followed. So again, you'll find that the more active you are at gestations, and this is really important because at some gestations, now 22, 23 weeks, people may deliver based on parental choice, but really once the baby develops significant IVH, we become, I would say, non-interventionalist based on unit protocols, and that can affect the rates with which you develop grade 3 and grade 4 IVH, and then also impact how you manage life-sustaining intensive care. And that a lot of babies who have withdrawal of care for bilateral grade 4 IVH really have it done because the thought is that it's universally got a very poor prognosis. There is data now to show that discrete unilateral grade 4 IVH does not have such a bad prognosis, and we need to be a little bit cautious about how we implement such strategies. We know that the incidence of IVH has come down from the 1980s. I mean, Brazil has been able to bring it down from 50% to about 11% in 2005 with a good quality improvement bundle. This was implemented nationally. So, that's significant progress. It's quite interesting that in this last decade, Vermont Oxford network data for babies under 26 weeks shows that really the IVH rates tend to be static, anywhere between 10 to 18% in units. They haven't really come down quite significantly. And this really highlights the fact that, at this particular stage, if you look at grades of IVH, that, we're pretty much stagnant with where we are in terms of kind of the annual improvement in rates of IVH based on VON data. That being said, we know that babies who are born at 22 and 23 weeks tend to have higher rates of IVH as compared to babies who are more mature, where the rates of IVH are much, much lower. And really, the incidence of grade 3 and grade 4 IVH tends to be low in centers which practice, I would say, good golden hour care with really, I would say, a good pragmatic approach to blood pressure management, units which have high rates of steroid coverage. But even amongst countries, you can see that in Europe, if you take sources which report kind of IVH, the rates of grade 3 and grade 4 IVH can vary from as low as 5% in a center to up to 52%. So there's quite a large variation, despite, we'd say a lot of the European countries being classified as being high middle income countries, which should provide, good standards of intensive care. What is interesting is that population studies tend to underreport high rates of IVH, and this is possibly because they are single center studies, again, which basically look at units where they might be having good quality improvement strategies, whereas when you look at other distinct data sources, you might have quite a variable high rate. Now, the key thing from our perspective is IVH rates can be brought down with good quality improvement packages. And some of what we're going to talk about today in terms of being able to do screening ultrasound, the reasons for doing it are basically not just to basically diagnose IVH, but also to see how severe it is. In terms of pathophysiology, we know that prematurity is the single most important risk factor, babies under 1,500 grams. But if you don't have antenatal steroids, have bad RDS, get intubated, have surfactant, or develop a pneumothorax, your risk of an IVH goes up. The more preterm you are, 22, 23 weeks, the higher that risk. If you have extensive resuscitation doses of adrenaline, if you've received boluses of soda bicarb, if you kind of are outborn, you've needed neonatal transport, all of these are risk factors. And why are they risk factors? Because we know that preterm babies have blood vessels within the germinal matrix that basically have a simple endothelial lining without any parasites. that basically means that that structure for support of these blood vessels, especially if there's sudden increases in pressure, which all these things will predispose to, mean that they will rupture. And really, one of the important things is they have fewer glial fibers as well. And those glial fibers are quite important because they're responsible for actually not just support, but repair. So actually, if you rupture and you damage these glial fibers, the ability to kind of repair for those glial fibers to migrate into the right place and kind of help you neurodevelopmentally becomes quite impaired. But eventually, once the germinal matrix hemorrhages, it hemorrhages to a certain amount. And that largely is dependent on the ability of the brain to maintain blood flow or auto-regulate. Now, that's affected naturally by hypocarbia, by low blood pressure. So if you have low blood pressure and hypocarbia, you are going to have problems with low blood flow in that region. And hypocarbia will cause cranial vasoconstriction. But if you don't have constant blood flow, you have what I would say is so this kind of blood flow, which we call pulsatile. So if you have this kind of an effective blood flow, sorry, my marker is not working today. Really disappointing why it doesn't work sometimes. Maybe it's the ink color. No, not working. So pulsatile blood flow, where you have lack of autoregulation, basically will cause hemorrhage. And this is just a visual aspect of it. So really, this is the endothelium in an extremely preterm baby. It's very immature, single-celled, with absolutely no parasites. This is the supporting parasite tissue. And then you basically have these glial astrocytes, which basically have feet. These are very important because they are omnipotent. They have the ability to differentiate and then develop into further basement membrane covering neurons. But really, if you're deficient in these glial astrocytes and they are immature and have fewer feet, then really this is what an immature kind of a blood vasculature looks like. And really, if you look at the coronal section of the bloodstream, the lateral ventricle basically has this margin over here, and that's where the germinal matrix is concentrated. So if you look at this image, a lot of people sometimes feel confused. So the ventricle, basically, this is the lateral ventricle, and they think that the germinal matrix is within the lateral ventricle where the choroid is. It's not. It's actually outside the margin at the lateral wall of the lateral ventricle. And really, the choroid plexus is over here. So from our perspective, it's changes and bleeds in this germinal matrix over here that basically spread from the choroid into the ventricle. And then basically as they increase, we have increasing collection, which then fills the ventricle. And in bad situations, what happens is that once this ventricle and this choroid gets filled with bloods, it causes problems with venous egress, edema, which basically causes interstitial problems with the venous circulation over here. And if this basically prevents blood from going out, eventually blood dams up, and that's when you get a grade 4 IVH, which is very much fan-shaped. So actually the etiology of grade 1 to 3 IVH is different to the grade 4 IVH, which is predominantly what we call a venous infarction. Whereas bleeding, I would say, at this particular point, could be at the capillary level, at the venular level over here, and at the arterial level, depending on really what blood pressure fluctuations are taking place. The kind of thought that a grade 4 IVH was an IVH that extended from inside the ventricle outside is something that is just not supported by this hypothesis. Now, it does occur, but it's very uncommon. And Dr. Dubowitz, who's done all the research on it, basically says that it is something that he has seen very occasionally. And the giveaway is that if you have a hemorrhagic parenchymal infarct in the lateral margins, it will compress. You'll have ipsilateral blood, but the ventricles won't appear distended. On the other hand, if you have distended ventricles with blood going out, that may be a marker that you've bled from inside outside. And generally in term babies who may have coagulopathies or ITP, say for example, those are babies who can have intraventricular bleeding that then spreads out into the parenchyma. It is rare, it is uncommon. The more common hypothesis is venous infarction. The consequences are not good because really from our perspective, when this IVH is present, depending on its grade, and especially if it involves the parenchyma, or if it's bilateral and causes clots, you can develop post-hemorrhagic hydrocephalus, periventricular leukomalacia later on, especially if you've had problems with compression and ischemia of the ipsilateral parenchyma. And eventually in the long term, you can develop cerebral palsy and neurodevelopmental impairment. It is also known that some babies have genes that predispose to it. I'm not going to go into a lot of detail with that. In terms of clinical presentation, what is quite crucial to highlight is really the fact that from our perspective, most of these babies tend to be asymptomatic. So the American Academy of Pediatrics really doesn't talk about scanning these babies pretty much until day 7. They talk about a scan being done uh, on day 7 in babies less than 30 weeks, whereas Terry Inder and her colleagues have talked about the importance of diagnosing intracranial hemorrhage and IVH as early as day 1 because it tells you about the size progression, whether it might be antenatal or not. And really, it forms the basis for further screening, especially if you decide that you want to grade, quantify, and try and manage this IVH. I think hence most of the units that I've practiced in have always done scans on day 1. But really, some babies will show clinical neurological deterioration. And really, my experience is that a drop in hemoglobin with a sudden increase in ventilation is one of the common findings of a severe IVH. But subtle IVH may present with a baby who, basically, from our perspective, is a little bit more obtunded, showing paucity of movements, hypotonia. Now, that's quite difficult at 22 to 24 weeks of gestation because we don't touch these babies anyway. So how do you make the diagnosis? And really, what I'd say is that increasing ventilation requirements that are unexplained with small drops in hemoglobin should really prompt you to think that you might be having low-grade IVH in these babies. Now, a day 1 scan would naturally exclude any IVH, and then really its index of suspicion that would prompt you to scan again. But really, the protocols talk about scans at day 1, 3, 7, 14. And the expectation is that because 50% of IVH was deemed to present in the first 24 hours, that you'd pick up any antenatal bleeding, and that if anything were to progress or new bleeds were to develop, doing a day 3 scan would help you pick that up. Some babies will become very sick, they'll become hypertensive, acidotic, but really the important thing is that about 90% of IVH is diagnosed within the first 3 days for babies under 32 weeks. What has changed a little bit, and there's a study that basically demonstrates that actually when we looked at works that were done before 2007, in particular work done by Victor Dubowitz, Papil and his colleagues, and I would say Volpe, that a lot of that work showed that most of the IVH that occurred within 6 hours of life. And the reason for that is steroid cover prior to this duration was quite poor. We know that antenatal steroid cover started to improve around 2007. And really, in the decade after that, the other thing that improved was we were giving babies a lot more surfactant as well. Now, interestingly, doses of surfactant decrease and impair cerebral autoregulation and have themselves been linked to IVH. But I suspect improvements in our management alongside steroids, better management of RDS, better management of hypocarbia have all contributed to the fact that the incidence of IVH decreased up till that duration. So we know it decreased from the 80s to the first decade of the 2000s. But really, the epidemiology of clinical presentation has moved for the trend to appear on scans really around 24 to 48 hours of life now. And that is probably because a lot of these babies at this particular point are left untouched, unhandled. There's a lot of, I would say, espoused golden hour practice, which means they kind of become a little bit more vulnerable at a later stage. This is just a graph that demonstrates that. And you can see that for studies before 2007, actually in yellow, we tended to have a surge in the rates of IVH around 6 to 12 hours, so higher, and then basically plateauing. But really, what we've seen now is that with good golden hour management, antenatal steroid cover, and good golden hour practice, the incidence of IVH has really gone down. And really, from our perspective, if you look at after 2007, which is the graph over here, it tends to peak about 48 hours of age. So really, from our perspective, slight shift in the epidemiology. How do we diagnose it? Well, it's cranial ultrasound. We don't routinely do MRIs and CTs unless they're part of some research trial and there's an MRI on the CT on the unit. I doubt very much that actually anybody uses that in clinical practice, but feel free to correct me. The grading of IVH is important, and we have two classifications. We've got Papill's classification and we've got Volpe's classification. Papill's classification is quite simple. So if you have a hemorrhage that's basically located in the germinal matrix, so simple example from my perspective, if it's over here in the germinal matrix and small, it's grade 1. If it's kind of filling the lateral ventricle but not causing distension of the lateral ventricle or dilatation, it's grade 2. If the ventricle suddenly becomes enlarged and there's blood, then it's grade 3. And if it involves any of the cerebral parenchyma, it becomes grade 4. Now, the challenge with this was a lot of the imaging that was done at this particular stage was looking at coronal and sagittal views. And really, a very big problem, with these views was the fact that you could have blood that was within the lateral ventricle in the anterior horn, visible on the coronal view, that is not really significant. But then when you go to the sagittal views, the cross-sectional views over here, you find that the posterior part of the horn is full of blood. And really, if you're looking at this view, really, you can, from your perspective, have a larger amount of blood in this particular view on the sagittal sections. Now, the question is, are they both equivalent? And for that reason, Volpe decided to modify this and really added in the concept of the volume of blood in the ventricular area that it covers, and basically emphasized the importance of basically doing parasagittal views alongside with your coronal views to basically quantify an IVH. In fact, if you're doing and using Volpe's classification, you have to use the parasagittal views. So again, a very small bleed covering less than 10% of the ventricular area is a grade 1. A grade 2 is basically 10 to 50%. More than 50% is grade 3. That has been modified again with some people adding in plus minus dilatation. But really, he didn't have a grade 4, but we've accepted modifications now to say that if you have a periventricular echo density, then really from your perspective, that would fulfill the needs of being a grade 4. And that's important because we know that even grade 2 IVH, if there is significant blood in the ventricles, can still be associated with a parenchymal hemorrhagic infarct. And that really, even with its grade 2 volume, if you have parenchymal involvement, would still be classed as a grade 4 IVH. So I think what I would say is that research shows that both classifications have been used, but Volpe's classification is a little bit more, I would say, detailed and provides us the option of basically differentiating things based on parenchymal involvement. He talks about mentioning post-hemorrhagic ventricular dilatation separately if it's present, which this classification doesn't, because we know that in the latter phases, you may have dilatation of the ventricles. The question from our perspective then is how you use the classifications. And as I will show you images, which you will practice with today, it can be quite challenging sometimes to kind of subjectively interpret how much is 10 to 50%, how much is 50%, and whether or not we think that it fills the ventricle and goes into the cerebral parenchyma or not. So can anybody tell me at this particular point, which classification I'm using on the right side? So if you're looking at only coronal views, you're not using Volpe's classification. But this is just another kind of a view of the classification. So when you have the ventricles, and as you can see, so you've got an arterial supply. This is the ventricle over here. It's this paraventricular area that's really, really vulnerable. And it is drained by an artery with arterioles. And then you have these venules that basically take the blood away. Now, obviously, the brittle nature of the capillaries and the endothelium means bleeding will occur in this area, but then spread inside the ventricles. Now, naturally, if it's a small bleed, it's a grade 1, which classically we call a subependymal. Really, if we're kind of in a situation where the bleeding occurs outside of that, but there's no dilatation, then Papill's classification calls it a grade 2 limited IVH. If it's with dilatation, it's grade 3, also called an extensive IVH. And really, from your perspective, you can see that if there's hemorrhage in this zone, So if there's hemorrhage in this entire zone over here, it will affect, and edema will cause compression of these veins, which means that blood cannot go into the internal cerebral vein. That causes back pressure and eventually causes hemorrhage in the entire area of the parenchyma. And this basically is ipsilateral to the blood. So this is venous infarction for you. Now you can have grade 3 with a venous infarction that would still be classed as a grade 4 IVH. You can have grade 2 with a venous infarction, and that would still be classed as a grade 4 IVH. And that's important because, really, from our perspective, a lot of authors now say that we should move away from the grading system and really describe what you can see. Describe it in detail, and when you do serial scans, keep those descriptors uniform for chronological sake. And that might mean that I described this as being a large amount of blood causing the ventricle to be distended, with blood seen in the ipsilateral parenchyma, which suggests to me that this is a parenchymal hemorrhagic infarct, rather than saying this is a grade 4. The challenge from our perspective is we can't get away from grades at the moment because research and how we classify and fill in our NNAP data, as well as data for the Vermont-Oxford network, basically necessitates that we use grades. So some units will describe their scans, but then assign a grade. And basically that really is for the purposes of the NNAP database and the Vermont-Oxford network. I'm basically not going to cover sequelae in detail because I want to go to the scan side of things very quickly. And the important thing to emphasize is that an IVH can resolve completely, grade 1s and 2s, and leave nothing, so that the brain basically looks normal when you do the term equivalent scan. On the other hand, you can develop post-hemorrhagic ventricular dilatation, which is more commonly seen with grade 3 and grade 4 IVH. It is rarely seen with grade 2 IVH, about 5 to 10%, depending on studies. It's very, very uncommon. So 1 in 10 babies, really, from our perspective, would show dilatation if there was a grade 2 IVH. And that might be simple, small, prominent ventricles, which then basically get back together again. We know that the ventricle can get destroyed and eat into the brain, but effects of an IVH, basically release of hemosiderin, hemoglobin, iron, the problems with glutamate toxicity and oxidative stress cause problems with axonal damage in the periventricular areas. So these areas basically lose their nerve cells. We also know that the oligodendroglia, those nerve cells that support and migrate into this area, also undergo apoptosis. And eventually what you have is you have problems with white matter injury. At the end of the day, a grade 1 IVH can develop into a subependymal cyst, but grade 3 to 4 IVH may eventually develop into large cysts that are called porencephalic cysts, or they may evolve into periventricular leukomalacia. So simple, grade 1, very simple. In the chorothalamic notch, as you can see over here, and this is how it appears. This is the right side. So you can see it over here. The choroid looks quite bulky on this side and bright. So it's a very simple clot. And the prognosis for this is usually it will heal. Some of them will form a small subependymal cyst as we go forwards. And really, from our perspective, the majority of them will heal to the point where you don't see anything. But a small subependymal cyst may present in this region over here. This is basically, from our perspective, another image which shows the same grade 1. These are bilateral grade 1s that you can see. Always confirm these findings in 2 dimensions. Because if you don't confirm them in 2 dimensions, the risk is, again, if you're just using Papil's classification, what looks like a grade 1 in this view on the right side may actually look much larger if you use Volpe's review. And really, this is a grade 2. Now, the challenge that comes is the definition is that the echogenic blood should be filling less than 50% of the ventricle. Now, this is the ventricle, and this is how slit-shaped it looks. This is normal. And really, this is abnormal. Now, some people would classify this as a grade 3, but in reality, if you look at the ventricle, it's not fully filled, and you have bulky choroids anyway. So by definition, this small area is basically filling less than 50% of the ventricular area. So can you see the subjectivity of difference that this creates? Because a lot of people would class this as a grade 3 IVH, but actually it's a grade 2 IVH if you take the definition. Go further on, and really what you start seeing is grade 3 IVH with ventricular dilatation. And with the ventricular dilatation, again, the definition changes. It's covering more than 50% of the ventricle. You've got clot all the way here. This is the choroid plexus that you see over here. Again, this is a grade 3 IVH that you can see over here. And even the temporal horns have got clots in them. So you can see the clot extending all the way to the bottom over here, where you would not normally see choroid. So you can see the clot over here. So these are the temporal horns that you saw when Shona showed her beautiful scan today. This is just another example of grade 3 IVH. And clearly you can see that, from your perspective, you are filling more than 50% of the ventricle, always seen on the sagittal views. Here, the ventricle is not visible at all. So just the nature of the scan kind of means that we don't quite have echogenic blood. This is probably quite fresh, and the blood has not yet become it's isoechoic as opposed to being hyperechoic at this particular point because it's a fresh bleed. But if you look at it, the ventricle's not visible and it's pretty dilated. So this is, again, just another example of a grade 3, which fills the whole ventricle. So by definition, more than 50%. Again, this fills more than 50% of the ventricle. If you look at the whole hemorrhage, this is the choroid that you see over here, but the rest of it is all hemorrhage and clot. That's more than 50% of what you see is free, and it's dilated. Now, the dilatation would be, and that is why we do day 1 scans, because actually a day 1 scan gives you a baseline. Now, I know that where I currently work, we tend to allow for a scan up to 3 days. I know that having worked in Portsmouth and Southampton, we'd always do a golden hour sweep, just a single scan, which basically looked at the midline views and the sagittal views very quickly. So 60 seconds. And you basically get those views to be able to give you maturity, to be able to give you the ability to make sure that you can't see any significant congenital cystic problems, and that you're in a situation where if he's got no IVH, you've got a baseline from which, if the IVH develops, you can then quantify how much this blood is really filling the ventricles. I mean, what if this baby had large ventricles right from the start, which looked very, very bulky with its choroids, but had no hemorrhage? So it gives you the ability then for you to do serial kind of scans to make and fit these definitions. If you do this the first time around, you don't know what the ventricular size was. So, that's an argument in favor of what Terry Inder proposes and articles that are part of our library that give you the reasons for why we should be using Volpe's classification. Now, a grade 3 IVH, again, should always be looked at with both coronal, but always defined in the sagittal views. And the important thing is if you have bilateral grade 3 IVH, the risk of developing hydrocephalus is quite high. So just to give you a flavor, the risk of developing hydrocephalus with a grade 1 IVH, I have not seen one ever develop in my 2 decades of doing cranial ultrasound scans. I don't know if anybody else has. Clearly, we have a lot of people with a lot of experience over here. With grade 2 scans, the risk is between 5 and 10%. It's very low. So, 5% means that you'd have to do 1 in 20 babies, which, is very low. I think the risk is higher if you're more immature, again, because there are elements of ability and fragility that go beyond just the grade of hemorrhage. But with a grade 3 IVH and a grade 4 IVH, the risk of post-hemorrhagic ventricular dilatation goes up. So with bilateral grade 3s, the risks are about 50%. And with bilateral grade 4s, I mean, that risk is in the range of about 75%. So there's a high risk if you have a grade 3, grade 4 IVH of basically developing post-hemorrhagic hydrocephalus. And this is classically your hemorrhagic parenchymal infarct. Again, I'm just giving you a flavor to say that you have dilatation of the ventricles with clot inside, but this is the frontal area, and the frontal area has clot, which then extends posteriorly. To quantify accurately, you must have a look at your sagittal views. And really what you can see is this is an old IVH because you've really got cystic chains starting to develop over here. Okay, so let's open the floor. Let's do a little bit of work now. So Dr. Mbabi, can you hear me?
Yeah, I'm
Okay,
there.
Dr. Mbabi, this is an image that you can see in a 25-weeker The baby's hemoglobin kind of dropped from 18 to 11. He became acidotic. He's hypotensive. You have started a blood transfusion after having done this scan. So what can you see?
First image is sagittal view. I can see the both ventricles. The left one is more dilated than
So sagittal or coronal, my brother?
sorry, coronal view.
Yeah.
And the left ventricle is more enlarged and filled with blood than the right one.
Okay, this
There's
is right. This is right.
Hmm.
Sorry, my apologies, not labeled. Yeah, so you're right. The right, it's to your left. I understand what you're saying. But yeah, the right ventricle is filled with blood. Yep. What about the left?
The left is dilated and there is some blood there, but not much as the right one.
Okay, so possibly, yep, I agree. And really, when you look at the right sagittal view, what do you see?
The right sagittal, I couldn't see the dilatation of the ventricles. I think it's overlapped or filled with blood. So I couldn't see annotated the good. I think it's filled with blood, so I couldn't differentiate the ventricles well.
Okay, so we have Dr. Fatima. Dr. Fatima, can you help us? You're going to be Dr. Mbabi's friend. So you're both looking at the scan now.
Yes, doctor.
So what do you think?
I'm thinking like what he said that right side it's a IVH grade 3,
Hmm.
maybe because it's more than 50%.
Yep.
There is drop off something in the right side, little bit in the coronal view.
Yep.
I cannot see the full ventricles on the right side, but it's look like it's grade 3 IVH. In the left side, I don't think it's. There is some grade 1 maybe,
Sure.
grade 1. And on sagittal view, they also it's confirming that in the right side it's grade 3 IVH. It's full ventricles
Yep.
with the blood.
I would agree with both of you. I think you're right. So some people sometimes try not to overinterpret things. I can't see any fan-shaped margin over here. This looks like it's really restricted to the ventricles at this particular point. And this image is the giveaway. It is really restricted to the ventricles. From my perspective, the cortex over here doesn't appear involved at all. And then basically, this is really important. Because you have dilatation, as you move to your sagittal view on the right, you see something that you might confuse with the parenchyma. It's not. And this is really important. Can you see that you even have some of the midline coming in, like the corpus callosum over here? So you're somewhere in between, and this is not parenchymal involvement. So really, my message to you when you're looking at IVH, always move out to the lateral most aspect of the hemisphere to confirm that there's no parenchymal involvement. Because at this particular point, this is clinically a baby who's had an IVH, but this might progress and you might want to repeat your scan maybe in 24 hours. Does anybody think this is a grade 4? Happy to share views.
Yes, I think this is Tolulope.
Yeah, Tolulope, yep.
I think I'm actually confused. I thought that blood is get to the parenchyma, it's pressing outside the ventricle.
Yep. Okay, so what I'd say is that if there is that confusion, then you need to basically move further out, because my worry at the moment is that if you just interpret with this image, you're somewhere between the midline and the outer view. And this could just reflect this clot over here. You get what I'm saying? Not really a clot in the parenchyma.
Okay.
So I
Okay.
would move further out. And
Mhm.
when you move further out in this scan, and I haven't shown you that image for want of time, then actually you see the parenchyma is completely spared. But that is the reason I'm showing you this, to kind of emphasize that it can be really confusing, because this is what a proper grade 4 looks like. Can you see the parenchymal involvement here? There's no fanning over here. This is classically fan-shaped.
Okay.
Again, this is very fan-shaped, bilateral grade 4 IVH.
Okay.
And that's a unilateral grade 4 IVH. What about this one, Dr. Tolarope?
This one, I think this one will be grade 3.
Okay, so let's phone a friend, Dr. Tolalupe. You got any friends over here?
Maybe Dr. Fatma.
Okay, Dr. Fatima, you've been requested.
Okay. I think also parenchyma, it's involved on that view. Yeah, here. Some
There?
yeah, that's what I'm seeing.
Okay.
What do you think?
Okay, so I would agree. Now, this is a really important slide. And why am I showing you these slides? So you can have a baby who you've scanned on day 1, who from your perspective had very bad flare in this region. Now, he may have antenatal periventricular leukomalacia because of antenatal hypoxia ischemia. And then you develop a bleed. So that is the importance of having your day 1 scans. So you know whether this is periventricular blush or not. My only comment is that this is blood bright. This is also blood bright. So experience says if I didn't have a scan on day 1 that marked this as blush, I would probably class this as a grade 4 IVH at this particular point. My take-home message to you is you never make a diagnosis of IVH with one plane. You make the diagnosis with 2 planes. So you must see what your coronal plane also shows. But to grade IVH, you have to do the parasagittal planes. That is very, very, very important. Okay? Okay, what about here? So when you look at the scan, you can see IVH in evolution. And really, from my perspective, when you look at the IVH in evolution, you can see how a small IVH can become a bigger IVH, and that this is a small subependymal bleed, really a grade 2 possibly, which basically then develops into a grade 3 with extension. The choroid doesn't appear as bright at this particular point, but then you find that the choroid is also bled. It's very bright, and you have significant dilatation of the ventricle. So this is basically evolution of an IVH. But this is natural evolution, and you don't see a grade 4 at this particular point. On the other hand, what do we see over here? So who are we going to choose? Shinza.
Yes, doctor.
Okay, so a small asymptomatic baby who basically from our perspective had a scan which was kind of done on day 3. And these are the images. Right is this side where you see my marker, and left is this side. And this is right, and this is right axial.
So on the first image, it essentially almost looks normal, except from on the left side, the ventricles look a little bit smaller, but
Yeah,
I think other than that,
smaller and septate actually. There's a septation. So yeah. What about the right side?
the right side, the top bit looks missing, the top part of the ventricle, but towards the end you see like a dilatation almost.
This area here?
Yeah.
Okay, fair point. Okay. So asymmetrical ventricles and
Yes.
what looks like could be either bulky choroid or a grade 1.
Yeah.
Okay. And then you basically go into the right sagittal. So what do you think about the right sagittal?
There definitely seems to be a bleed, but it's less than 50%. So I'd put it like between grade 1 and grade 2.
Yep. Yep. So those are the challenges that you kind of, you might have confusion. And really, when you look at the axial view, it's completely clear. On the right axial view, you actually see that there's nothing, but it's quite interesting. When you look at the left side, can you see clot over here? That wasn't visible. I haven't shown you
Yeah.
the left view on this, but it's just to give you an idea that actually it can be quite confusing labeling them. And it can be quite important because really, if you have a grade 2 IVH, it's not without its problems later on in life. So it can have significant implications. Now, my question to you is, if you had a grade 2 IVH in a baby and this completely resolved prognostically, that's good. But in terms of using the grade of IVH to prognosticate parents, the fact that you had a grade 2 IVH, is that more important or is it the fact that it resolved?
The fact that it resolved, but I don't know why.
Okay, anybody? Does anybody have any thoughts on this prognosis? We have a whole talk on it. So I'm going to give you some homework today. I like to give people homework now that we're going into our second month. Today is the 6th. So we started our second month today. And my expectation is we're now talking about pathology, but we need to know about prognosis, not just diagnosis, because you'll all be diagnosing things. But the question is, you will have to have conversations with parents. Your consultants will have to have conversations with parents. And the two pathologies that I would really like to talk about, and I think we're going to stay with IVH today. I'm not going to cover PVL today because I think it'll kill you guys to do that. But really, prognosis for IVH and how we counsel parents has implications about the grade of hemorrhage, the clinical course, and the clinical course and symptomatology that the baby takes. Really, any complications that the baby develops. But more importantly, what is important is the term equivalent scan. And in some babies, some of us would elect to do MRIs based on certain appearances. And I'm not going to go into those details today. We're going to talk about that more with prognosis. So I want you all to read about these issues. And I'm going to share the article library with you today, the articles that I want you to read to kind of come to consensus. Because at the end of the day, when we do workshops towards the end of this month, a lot of it will be your take. We'll be dividing you into groups of 2 and you'll be counseling. We'll be doing a lot of role play where we'll be showing you scans and you'll have to speak to the parents. So
I
that's
would
why
say that
labeling is so important.
it's on the right side we would see it because it really looks like an infarction, right?
So hemorrhagic parenchymal infarct or flare?
For me, it looks like an infarction, but we can see it because we don't have the right sagittal.
Brilliant. So labeling is quite crucial at this particular point. And what is really important is that you're not making an interpretation with wrong labeling, because the left side actually doesn't show hemorrhage, it shows a bulky choroid. So you only have a grade 1. So it's really important that you've labeled these images appropriately. Now, the challenge from our perspective is we don't have the left and right labeling. And I have taken this picture from a journal. So I don't know whether this is left or right. But what does the image here tell you when you talk about this as being flare or a grade 4, Maria?
So the shape, it really looks like the territory of the venous pattern. So it looks like there is a compression on the venous sides, that it could be just edema and then regress, or it could be hemorrhage and then progress into cysts. So that depends how much the compression on the venous side is important.
So two very important take-home messages over here. Two very important take-home messages before I show you the progression are, once we talked about labeling, but the second thing is look at the evolution. So this is a porencephalic cyst.
Yeah.
A porencephalic cyst is usually found with
infarction.
Yeah, with a hemorrhagic parenchymal infarct. On the other hand, with, say, if this was flare and you tend to find cystic periventricular leukomalacia, you'd find multiple small cysts as opposed to having a large porencephalic cyst. So again, if there's confusion, I think the message that I'm trying to give you is that people can interpret this slide in different ways. Somebody may say, well, this is a low grade kind of grade 2 maybe. We need to see what the sagittal view shows. But is this flare or is this an infarct? It's fan shaped, so some people might call it an infarct. Some people might feel it's flare. But once you see the evolution, if there's parenchyma involved on the correct sagittal view, and it leaves and develops into a porencephalic cyst, it's more likely that this was a right-sided grade 4 IVH. Do you get what I'm saying? So hence the reason why a lot of people have gone into describing this as opposed to kind of using grades for it. Because on the other hand, if you found that this is really more of kind of periventricular leukomalacia of a cystic variety, then really, rather than labeling this a grade 4, this could be just really, really bad. It could still be infarction in that area because we know that hypoxia ischemia is the most common reason for periventricular leukomalacia. But rather than evolving into a porencephalic cyst, that would evolve into cystic, microcystic kind of appearance. Do you get what I'm saying?
Yes.
I think that's where I would say that you have to be extremely cautious with how you're basically describing your images. And rather than having, like, I can tell you for a fact, this baby would have had a lot of scans in between. But if you just interpret a scan from 3 days of age with a scan with 9 weeks of age, it doesn't tell you the whole story. And that's why what you really need to do is you need to basically be able to classify scans into days from 0 onwards. Now, why do we do a day 1 scan? This is why we do a day 1 scan. So, Maria, would you like to interpret the scan? Now, just remember, this is right and this is left.
Yes. So right on the right side, it looks like there is a grade 3 for the Volpe classification, which would be a grade 2 for Papai, right? Because there is no dilatation, but the ventricle is filled with the blood, and it looks like there is a compression for sure on the venous system, so it could have bled in utero, right?
Yep. So
And
if this is the right side, this is the left side, this is the right side, this is the left side, that's the left. This is the right, and this is the midline.
yeah, so the left has a grade 3 as well, right? So it's a grade 3 on one side and a grade 3 plus a parenchymal hyperintensity that only time is going to tell us if it's the actual infarction or just edema.
Okay. Some people would label the right side as a grade 4.
Okay.
Do you think? Because no delineation. But again, just coming back to my last image, it's very dense. That could be flare as well. And I understand why you might label that as a grade 3. It might just be flare, ischemic
Yeah.
area. It might be ischemia in the parenchyma. And
Is
that is,
yeah, no, sorry. It's just that I understand. I use the Volpe classification
yep,
basically always. So
yep,
that's why I would say grade 3 plus
yep, 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 yep. I get
hyperintensity.
what you're saying. So you're using the Volpe in its true sense. You know that the Volpe has also been modified by research analysts. So Ruera et al. Have kind of revised it and added it and basically called it a grade 4. So I get what you're saying. You're using the
Okay.
pure Volpe. But yeah, by Papil's classification, what do you think? Would it be a right grade 4?
Sure, yeah.
Okay. And a left?
Left grade 3,
Okay.
maybe.
Yep. And what do you think on day 6?
So on this, so the sagittal is left. Sorry, because I'm on the phone. I can't see the
No problems.
okay.
Yep.
Yeah, so still 4 on the right and 3 on the left.
Okay. And 2 weeks into it?
2 weeks. Yeah, there is both of them are dilated, and the third ventricle as well. Doesn't look like I can see the fourth, but it doesn't look like it's dilated. So looks like a dilation on the lateral ventricle and third ventricle, plus ventriculitis, and a grade 4 on the right, and still a grade 3 on the left with a significant dilatation.
Yep. So basically, if I said the head circumference has gone up and is high, and basically the VIs here are 4 millimeters plus 97th, these VIs, and it's tricky.
Yeah.
So when you measure VIs, again, just to give people a flavor, it can be really tricky as to how you do it when you have an IVH. And that where that ventricular margin is very difficult to define. So really, if this is the area that you define, where do you define your ventricular margin over here? But we know the ventricles are dilated. Here, it's much easier. So you'd have to basically, with the eye of faith, take a margin, which is a little bit of a guesstimate. But for all practical purposes, this baby with an enlarging head circumference has got hydrocephalus. Now, do you think this baby was treated or not treated?
With we treated for the hydrocephalus. Yeah,
Yeah.
it would make sense. It really depends on the center. I've worked in centers where they were waiting longer than the 4 centimeter above the 97 cell type. But yeah,
Okay.
you're treating now at the 97, right? Even.
Yep. Yep. So, I mean, treatment methodology, let's assume this baby had lumbar punctures, multiple episodes, and at 6 weeks of life, what do you see?
It looks like the extra the extra spaces are enlarged, so it would be either some brain atrophy or
Very good.
I mean just the MRI that could tell us, and is yes it would. And yeah, so the ventricles are much better in terms of dilatation.
Yep.
Yeah, it didn't evolve into a complete cyst, so I would say prognostically is not, I mean, it's not ideal, but it's not as bad as the case before.
Yep. You're right. I mean, with the eye of faith, uh, probably the hydrocephalus arrested, but the baby's got significant extraaxial space, so there's cerebral atrophy. We know that the left side was not so bad, but the right side basically has still got clot in it, which is still it's at risk. And I'm just saying that I've known babies to go into arrested hydrocephalus and then they can develop infection or other things. And we had a baby who then went on to develop hydrocephalus. But what is very worrying is this margin that you see on the right side, just in terms of parenchymal involvement. I just really worry about the notching of the ventricle over here. And because I can see the Sylvian fissure,
Yeah.
there is probably an overlap between the cortex over here as well as the ventricle. And that's, again, I just want everybody, when you have images like this, you should go right out to the extreme area of the cortex to try and make sure that if there is any kind of porencephaly developing or cystic change developing, that you capture it. Okay. But I mean, overall, this baby still has a long journey to go because he's got cerebral atrophy. Okay. What about this slide? Who do I pick on now? Rebecca, can you hear me? Okay, Wafa. Can you hear me, Wafa? Okay, Wafa can't hear me.
Okay, I can interpret.
Okay, go for it, Bobby.
For the coronal view, the right ventricle is a bigger size than the left one, and there is localized blood clotted there. Also, there is cystic change in the right side more than the left one.
Yep.
So I think this is the grade 4 in the left in the right side.
Yep.
Also in the sagittal view, also there is I think this is the right side for the sagittal view.
Yep.
Because of the cystic formation for the parenchyma and cystic change, bronchocephalic cyst, and there is still hemorrhage inside the ventricle.
Very good. And that's why I wanted to show you the previous image. So really, this could still evolve. And, we're 6 weeks. Now, if this is a baby who was 24 weeks, if you look at the kind of sulcal gyral maturation, it's a very immature, smooth brain, which is starting to develop a sulcal gyral pattern over here. This baby is still just 30 weeks of age. And what is very important is that serial kind of scans being done haven't stopped over here, because this notched area over here could still evolve into a clinical picture like this, depending on how the clot evolves. So it's really important. What we normally recommend, and I know that our unit protocol is that we stop scanning at 34 weeks corrected gestation, but really follow-up should occur until at least term. And in babies like this, really, what I would say is if you have arrested hydrocephalus, you should always have a pre-discharge scan. You should be monitoring the head circumference very closely. You should be looking to try and optimize nutrition and support for this baby. My experience is that really a lot of the neuronal plasticity that you see, this is basically what is a unilateral grade 4. And a unilateral grade 4, basically, from my perspective, has, depending on its size, now this is quite large. What do you think the prognosis is going to be, Maria?
Clinically, this really looks like there's going to be a cerebral palsy and a neurodevelopmental impairment.
Okay.
Because all the frontal part and the parietal, they're all damaged.
Okay, cerebral palsy is quite a broad term. Severe end of the spectrum, what do you think? This is going to be really bad. He's going to be in a wheelchair. He's not going to go to school.
Okay, I'm not.
Somebody to help Maria? Anybody have an opinion?
Maybe
he will have a unilateral deficit, like unilateral cerebral palsy.
Yeah, hemiplegic CB.
Okay. Okay. So what I'd say is that really this is frontal, a very frontal, a little bit parietal. It is unilateral. There's clot still in it. It may be, from our perspective, that the opposite side of the brain still being intact can take a lot of the glial fibers that would have normally migrated to the right side, and the left side of the brain, having its neural plasticity, can actually take over some of the functions of the right side. But there's a very nice article which is part of your library. There are 4. And really, from our perspective, if it's just frontal with a little bit of parietal, prognosis is not so bad. Now, for me, it's more the fact that it's quite large and extensive that makes me feel worried at this stage. And if this was the scan, say, at about 36 weeks, I would almost certainly, from my perspective, be repeating a scan at 40 weeks to kind of look at progress and see how this area, which really looks like it's got periventricular kind of leukomalacia evolving, moves. If it gets wider and involves the parietal lobes and goes to the back of the brain, we're in big trouble. But if it stays here and it heals and it's just frontal part of the brain, then prognosis actually says that, yep, there's risk of possible hemiplegic CP. Be very careful about talking about wheelchairs, simply because there is no good evidence that ultrasound findings per se can quantify the severity of neurological deficits. Again, a very nice paper from Davis, which is part of the article library, which talks about it. I think from our perspective, really, I would be very cautious at this particular point when I'm speaking to the parents of saying, Weakness on one side of the body is possible. We can't say how severe it might be. What about cognitive effects? Maria, any thoughts about cognitive effects? Do you think this kid will be good at maths in school?
It will be affected because it's frontal also.
So you'd be surprised actually with the frontal lobe, again, the ability to kind of remodel and neuronal plasticity, work done by Mater, which is probably a large piece of work. I can't tell you numbers, but 2/3 of those babies had normal cognitive function. And that brings me to the slide on prognosis. So what we know from our perspective is that previously it used to be thought that grade 1 to 2 IVH was associated with little risk of disability. We used to kind of say that if a grade 1 or 2 completely resolved and left no sequelae, this kid should be as good as gold. We also had work that's been done by Neil Marlowe and his group in the first Epicure study, which was done in 1995, which basically showed that if you had a grade 1 to 2 IVH and you had no IVH, babies with no IVH actually did worse than them. But actually, the fact is, we now know from a large amount of work, and again, Patra et al.'s article is in the library, that really even kids with grade 2 IVH can show significant problems later on in life. They have at least a 5-point lower MDI scale, 74 versus 79, for kids who have no IVH. And really, from our perspective, there is an element of cerebral palsy that they can show. Cognitive impairment is not so marked, but behavioral problems have been described in children with grade 2 IVH. If you just look at the risk of CP without cognitive involvement, Sherlock and colleagues basically demonstrated that if you had a grade 2 IVH versus a grade 1 IVH, your risk of CP was 24% versus just 6%. So, that's quite a significant figure. For grade 3 IVH, no doubt that you're going to have some kind of neurological consequences. And Volpe basically did a meta-analysis of studies. These are quite old, obviously. These are from the decades prior to the 2000s. And he estimated at that time that if you had grade 3 IVH, especially if you had bilateral grade 3 IVH, your risk of having neurological consequences was about 50%. More recent work done by Futagi, again, which is a Japanese author, basically says that about 23% of survivors with grade 3 IVH, babies under 30 weeks, 26 weeks of gestation, really go on to develop CP versus just 17% with grade 2 and 7% with grade 1 IVH. So much higher rates. But unilateral grade 4s or parenchymal hemorrhagic infarcts have better prognosis than grade 4s that are bilateral. In terms of motor problems, depending on the areas that are involved, I mean, if you have a very discrete grade 4 involving the frontal region with no development of post-hemorrhagic ventricular dilatation, motor problems have been reported to be as low as 8%. But 2/3 of these children with unilateral grade 4s, even decent sized ones, can actually be normal cognitively. They can go to normal school. And I can tell you of the 7 that I've followed up, 4 of them, 5 actually, are going to normal school at this particular point. A lot of it depends on the size, and I would say that size is quite a worry over here. But I wouldn't be writing anybody off, and I would not be going into the exact terminology of what this baby is going to do in terms of going to school, whether he's going to play hockey, whether he's going to swim. I would not go there at this particular point. I think really what you need is neurodevelopmental follow-up done quite frequently up till the age of at least 3 to be able to prognosticate what this baby is going to be able to do. Scans alone, even MRIs, I'd be very cautious about giving definitive kind of prognosis based on those scans. If you look at bilateral grade 4, bilateral grade 4s are universally thought to have very poor prognosis. What do we think about that? Because we withdraw a lot based on bilateral grade 4s. Maria, any literature that you're aware of?
No.
Okay, so I'm going to leave this. So there's 2 homeworks that I want people to take from this today. Really, from my perspective is, I want us to think very closely about which classification you'd prefer using. Number one, whether you'd like to use the Papale and the Volpe and why, because I'm going to start with that in the next class when we talk about PVL. The second piece of homework that I would like us to think about is really uh, how we would apply this in the context of different cases. So we will have a quiz when we start the next session on, and those cases will have all the images and you will have to make the diagnosis. And then really what I'd like us to, the third piece of homework that I want to focus on is I want us to get a little bit more of a feel of what the prognosis is of bilateral grade 4 IVH in the last decade. So we used to think that bilateral grade 4 IVH had universally poor prognosis. Is that the case? Or are there some babies who we think might be goers? So three things. Any questions about today's session? Very important, very important. Always, when you're evaluating your IVH in summary, make sure that you're looking and demonstrating and looking at the IVH in two planes. There's a big difference between one coronal plane and sagittal planes that can change your diagnosis. If you're using Volpe's classification, you have to look at the sagittal planes as well. A very important other thing, always mark your slides. Can I just say that not marking your slides or getting side wrong can make things really confusing. And it's really important. I've showed you slides today which have not had markers on them. And you can see how easy it is to get confused, especially in this particular slide where you have left but no right marked. Again, really important that you label your slides correctly. And eventually, what I would say is that prognosis doesn't depend on just the highest grade of IVH, but that's another question for homework. Really, the evolution of IVH and how the brain looks like at the end. And in addition to that, I would say that some centers who have very good experts in being able to interpret MRI, I'd say, Linda DeVries Center, I'd say Mary Rutherford Center would have a lot more experience of being able to more accurately prognosticate than centers who just rely on cranial ultrasound alone. But it's that ability to have people who are very experienced in really interpreting MRI. But taking all of these things into account, just scans alone, not looking at the baby, not looking at the clinical course, not looking at clinical examination of the baby. If you just stick to a scan and try to prognosticate, you are making a very big mistake. I have seen really bad grade 4s. I've seen a really bad unilateral grade 4 in two cases. And the kids are currently 7 and 8 and they're going to normal school. They have behavioral problems, but really, in terms of their ability to be able to function, they're not great in their subjects. They don't have to be top of the class. So, I'm a 31 weeker. And I can tell you for a fact, my wife thinks that I had an IVH of some kind. She definitely thinks that I have CP somewhere. So, I would say be very cautious about your interpretations. Thank you very much. It's an interesting session. Again, PVL is another interesting session that we'll cover. But what is very important is the homework is very important today. So let's see what you think in the next session because we'll have a quiz when we start and then we'll talk about PVL. And there'll be homework with PVL as well. God bless you all. Thank you very much.
Thank you.